So injuries of the maxillofacial region, they involve both soft tissues and bones. We are going to specifically talk about bones right now. So in this era of fast life and expressive, the incidence of automobile accidents which results in multiple injuries including maxillofacial are significantly increasing, you all know. So the anatomy of basic face and its skeletal framework, you have an idea. So up there's the frontal bone, then there's ethmoid, orbit, nasal cavities, maxillary bone and mandible. So all these bones are पढ़ना है या नहीं पढ़ना अगर attendance होगी तो paper दे दो I'll go if you want to study I'll teach so all these bones that you can see these are all the bones that have the propensity to get fractured when you have a trauma and it gets a hit on the face. So you know these there can be various causes of having this. Now we talk about the basic reason. Maxillofacial trauma as such is divided into soft tissue injuries which are on the face like laceration, abrasions, and maxillofacial fractures and orbital fractures. There are fractures of the mandible. Maxillofacial trauma in children is a separate topic which we will cover later because these bones are more malleable and they don't get fractured as such. So maxillofacial region can be divided into three: upper, middle and lower one-third. The upper third lies above the supraorbital ridge while lower third consists of mandible and lower teeth. And the one in the middle third is between the supraorbital ridge and the angle of mouth. So you get an idea. If you see a line, that is supraorbital foramen. The line which divides the supraorbital foramen of both the sides is the supraorbital ridge. And below is the mandible and a horizontal line which is passing at the ramus. So that is the upper one-third, middle one-third and lower one-third. General principles you know, hourglass of trauma and all that. So resuscitation is important. Before getting to a particular fracture and its treatment, you have to first understand what is the general condition. Obviously, GCS scoring is important. You revive the patient, look at the CVS, CNS and all those and then come to the basic fracture treatment. So blunt trauma, you get an X-ray test done. This is all what is general, you know. Airway management is the most important thing. From ENT perspective, either you intubate the patient if he is not breathing, otherwise tracheostomy. So displacing the mandible and chin forward, I think आप लोगों का सबका BLS, ACLS हो चुका है, so you get an idea of how to manage. ABC, now it's BAC, which I think everybody has an idea, so we'll get to, sorry? That is your problem. I am not here to teach BLS. You have to first understand कि कोई भी patient या कोई भी बंदे का अगर accident होता है, so the first thing you have to secure is the airway. Once the airway is secured, then you look at the pulse and start doing what? CPR. What is CPR? Cardiopulmonary resuscitation. Initially, it was said that you start CPR first and then go with breath. But no, secure the airway prima facie. For example, if the patient is unconscious and you see there's a mandible fracture, so no amount of mouth-to-mouth breathing you do will not help. So in that case, secure the airway first. How? You can put an LMA. What is LMA? Laryngeal mask airway. It is a small tube which is smaller than endotracheal tube which does not have to go into the trachea. It stays till your oropharynx to keep that part of your pharynx dilated so that when you give a mouth-to-mouth breathing, the air reaches the trachea and henceforth into the lungs. So initially, anybody, it was I think up till 2018, people usually CPR first. They started giving what? Chest thumps. समझते हो chest thumps क्या होते हैं? When you start pumping the heart in cases of sudden shock in an unconscious patient. But now we first revive the airway and then go with pumping the heart. So that is CPR and all of you will be taught in BCLS and BLS how to do this. So we have to talk about maxillofacial fractures. Why I am talking about this is maxillofacial fractures have a very big propensity to block your airway. In such cases, if after intubation or after trying to intubate and after trying to put LMA, you're not able to secure the airway, plain short, go for tracheostomy. You do not have to wait even for the consent. If you have to revive the patient, then you have to do immediate tracheostomy. Try with cricothyrotomy. If you can do it, fine. If not, go with tracheostomy. But secure the airway, right? So maxillofacial trauma अगर extensive है तो आपको airway नहीं मिलेगा. In those cases, don't try to manipulate too much. You might cause more harm than good. Just go do a tracheostomy. ठीक है? So circulation, blood loss. So depending on the percentage of blood volume that is lost, we divide it into 4 classes. Class 1 is 15% of your total blood volume. Class 2 is 15 to 30% of your total blood volume. 3 is 30 to 40, and more than 40 is class 4. Now the condition of organ perfusion can be judged from pulse, BP, temperature, urine output, skin color and mental status. You do an ECG. ये सब ठीक है. Now we can talk about history and examination. See, the history and physical examination should include the following elements. One is airway assessment, hemorrhage, that is the amount of blood loss, and neurovascular status, whether the patient is conscious or not. Also look at the associated injuries in cases of cervical spine, eye and head, major systems and life-threatening injuries. See, always make a rule to rule out cervical spine injury. If in a patient of cervical spine you manipulate the neck too much, you will land up causing a paraplegia. So make sure that the first and foremost thing is stabilize the neck if you suspect a cervical spine injury, right? And take it for granted, if there are more than 2 bones fractured on your face except nasal bone. So excluding nasal bone, out of the 6 bones that we spoke, if there are 2 bones fractured, then we take it as a thumb of rule that the cervical spine might have had some effect. Not essentially a fracture, but maybe a hairline. In those cases, the first thing that we do is first stabilize the airway without moving patient much and then secure the neck. How do you secure the neck? You put a collar. When you do a first aid, you will see there are these big collars. So when you have more than 2 fractures of face except nasal bone, you put that collar, secure the airway, and then we are going to talk about what we will do next. So time and mechanism of injury, wound, blunt trauma, penetrating trauma, spontaneous fractures. The kind of trauma that you have is very important to understand the management of that trauma. So focused head and neck examination including orbit and globe, which is because the globe can have enophthalmos, diplopia, hypemia, corneal and scleral lacerations, movements, vision, visual field convergence, fundus. All this is eye examination. Facial skeleton and nose fractures, point of tenderness, crepitus, pain on function, cranial nerves, hyperesthesia, paresthesia, malocclusion, intraoral structures and soft tissue facial burns. All these are the kind of injuries that can happen, which you need to see when you do a detailed head and neck examination. So now we come to the more important part. The patient has been stabilized. You've either intubated or shifted him into the emergency after knowing that the airway and circulation is fine. Now we see what are the fractures that have happened on the facial skeleton. For that we do radiology. So plain radiograph, you can do Townes view, you can take lateral oblique for mandible, you can do a CT scan, and you can do a OPG. What is OPG? OPG is orthopentogram, which usually your dentists do when they need to see your last molars. So OPG has a very refined version for general facial fractures of ENT, where we have a complete mandible X-ray in a 3D view. That is known as orthopentogram. But nobody nowadays does so many X-rays separately. We have something known as 3D facial reconstruction CT, which is a very good high definition CT in which you get a complete bony picture. I'll show you of the entire face, and it's a 3D picture, so you can rotate and see where is that facial line, at which angle is it going, and where is it going, right? So it'll help you plan. For example, you want to do plating on the mandible and the line is going close to the nerve, and you put a plate and you start drilling, and you put a screw and you'll realize the screw is hitting the nerve. What will happen? you'll get paresthesias. You don't want that. So because of the 3D, it's very close to see whether that fracture line is passing the mental foramen or not, whether it is passing close to the intraorbital foramen or not. I'll show you. We have CTs here. So the axial cuts are best for frontal, naso-orbital ethmoid, zygomatic arch, vertical orbital wall fractures, while coronal sections are good for orbital roof, floor, and pterygoid plates. So this was the olden times when we did not have this reconstruction CT. We used to get CT scan done in axial and coronal planes. Now we don't get this done because the total cost of this CT would come out to be 4,500, and now we can get a 3D reconstruction in 5,000. So it's more easy and it's more convenient. It gives much more information, right? So see, what I've written is there's a 3D dimensional reconstruction display of overall facial architecture, which we will show you. So the lab investigations are the usual investigations that you'll get done. Now for soft tissue injuries like facial lacerations, you thoroughly clean them. Foreign materials are closed by accurate approximation layer by layer. Now for any facial fracture, think of parotid. Why? Because parotid is a gland which is very superficial and it can lead to a very disabling fistula. Why? Because a gland gets traumatized. See, parotid is more of a seromucinous gland. So mucin has a very bad propensity of, if the gland duct is traumatized, the mucin is going to come right below the skin, and as you know, it has enzymes. So it will start what proteolytic degradation of your soft tissues in your skin and lead a fistula. So every time you'll eat, you'll have saliva coming from your skin. So that is a trauma to parotid gland is very important to rule out. So exposed parotid tissue needs suturing. Injured to parotid duct are the more serious ones. Both ends of the injured parotid duct, which is tensils, should be identified and sutured with fine suture. You can use, nowadays we use Prolene and we use Vicryl. So Vicryl 5060 is very good for parotid duct resuturing. Now facial nerve, ENT is incomplete without facial nerve. You know, if there's ENT, there's facial. So facial nerve is severed, then you see what is the length of the severed section of your nerve. For example, if it is more than 1 mm, then there is no way you can do a reanastomosis. You will have to do a cable grafting. What do you understand by cable grafting? Yes, you're right. So you put some other nerve in between the two cut ends of the nerve. So for example, the facial nerve is cut over here. So it is coming out of the stylomastoid foramen. It is going to divide into 5 branches. So before it is dividing into 5 branches, let's say we get a trauma at the angle of mandible or ramus. What has happened? The facial nerve is severed. Now you have 2 cut ends which has a distance of about 2 centimeter. Now you can't stretch the nerve to resuture it. It is not skin. It does not have the tensile strength. So we use cable grafts. For example, what do we use? We use a sural nerve, yes. But for sural nerve, what will you have to? You will have to go and access the leg. So we have a better nerve which is known as greater auricular, which is available at the same site. So you can use greater auricular. It gives very good functional outcome. Now frontal sinus fractures, you can have a linear, a horizontal, linear, vertical and comminuted fractures of anterior and posterior wall. If there are anterior wall fractures, they may be depressed or they may be comminuted. What do you understand by comminuted? Comminuted fracture क्या होता है? So when a bone gets fractured, you can have a linear fracture, you can have a vertical linear or a horizontal linear fracture. Then there is something known as comminuted fracture, that a single piece of bone is broken into more than 3 pieces, but they are close to each other. So that is known as a comminuted fracture. Now in these fractures, frontal sinus is approached either through an existing external skin wound or through a brow incision. I think brow incision के बारे में भी आपको maxillectomy के time पे we have spoken about this. What is Lynch incision? I remember speaking to one batch during the practicals about what are the various incisions for maxillectomy. So while elevating the bone fragments, care must be taken not to strip them from the periosteum. अगर posterior wall का fracture है तो क्या होगा? Why is it more dangerous? हम कौन से साइनस की बात कर रहे हैं? So these fractures are commonly accompanied with dural tears, brain injury, CSF, rhinorrhea, and require neurosurgical management. So dural tears are repaired with temporalis and small frontal sinuses are obliterated with fat. Now injury to frontonasal duct. The chances of obstruction to sinus drainage are high and may result in a mucocele. To avoid this complication, a large communication between the sinus and the nose is created. Small frontal sinuses need complete removal of sinus mucosa and obliteration with fat. Now, supraorbital ridge. The supraorbital ridge fractures present with following signs and symptoms. There's periorbital ecchymosis and there's edema. There's flattening of the brow. There's proptosis or downward displacement of the eye. And there's impacted bone fragment in the orbit. Now, what do we do for these? We give a brow incision in the transverse skin line of the forehead and we lift the bone, right? So frontal bone fractures which often extend into the orbit can be depressed linear with or without separation. They are commonly associated with brain injury and cerebral edema and require neurosurgical management. Now nasal bones and septum, I think this is the most important from your UG perspective. Now you know because nose is the most prominent in the projecting part of the face, it is more prone to trauma. So the most common bone which is to be traumatized in cases of facial fractures is your nasal bone, right? So nasal bone fractures are the third most common fractures of the body. The first is clavicle and second is wrist. When we talk about facial skeleton, it is the most common bone to get fractured. So these are the various types of fractures that you can see. All of this is in your Dhingra, so it's okay. Now, magnitude and direction of traumatic force determine the depth and the type of injury. There are two types of nasal fractures. One is the depressed fracture and the other is angulated fracture. So, for example, you have a frontal blow, you'll get a depressed nasal bone. And when you have a lateral blow, which is an angulated blow, you'll get an angulated fracture and a comminuted fracture.